Welcome to my channel, Chemo Pharmacology 101. My name is Lisa and I am a board-certified oncology pharmacist. In this video, I will be talking about Elranatamab. Its brand name is Elrexfio. Elranatamab is a bispecific T-cell engager. Bispecific T-cell engagers are medications that act by binding a marker on tumor cells and the CD3 positive T-cells. By linking them together, it leads to T-cell activation and lysis of the tumor cells. The marker that this bispecific T-cell engager targets is BCMA, or B-cell maturation antigen. In an ideal world, the marker is only present on tumor cells and not normal tissue, but this is not always the case. Elranatamab is a bispecific T-cell engager that binds to BCMA on multiple myeloma cells and CD3 positive T cells. There are two different vial sizes of the Elranatamab subcutaneous product. Both are the strengths of the same medication, so they have the same concentration, but they're different dosing vial sizes to better facilitate the step-up dosing. The two vial sizes are 44 milligrams and a 76 milligram vial size. Patients receive lower doses at the beginning of therapy or step-up doses and then higher doses as they tolerate the lower doses. Elranatamab is FDA approved for relapsed or refractory multiple myeloma who have received at least 4 prior lines of therapy, including a proteasome inhibitor, an immunomodulatory agent, and an anti-CD38 monoclonal antibody. It is given as a subcutaneous injection, and doses are increased as patients tolerate the step-up dosing schedule. Premedications are required due to the risk of reactions, such as cytokine release syndrome. It's recommended to give acetaminophen, diphenhydramine, and dexamethasone approximately 1 hour before the Elranatamab dose. Patients who need a ramp back up or stepping back up due to a dosing delay, and those who have had cytokine release syndrome should continue receiving premedications. The first 2 doses of Elranatamab are recommended to be administered in the hospital. It is recommended to keep patients hospitalized for the first 48 hours after the first dose, and then for 24 hours after the second step-up doses. Doses may be shifted forward by 2 to 4 days depending on tolerability, but it is also recommended to have at least 2 days between step-up dose number 1 and step-up dose number 2. It is also recommended to have a minimum of 3 days between step-up dose number 2 and the first full treatment dose. As you can see on this slide, step-up dose number 1 is a 12 milligram dose. Step-up dose number 2 is a 32 milligram dose, and the full dose or the treatment dose is 76 milligrams. If patients need to, they can delay their next dose for up to 14 days to allow for full resolution of any adverse effects that can occur. And due to the shifting, even though it is recommended or it was studied as days 1, 4, and 8, some institutions do use a 1-3-6 dosing schedule, depending on how the inpatient to outpatient transition goes. Elranatamab should be administered via subcutaneous injection under the skin. The preferred administration site is the abdomen, but other sites, such as the thigh, can be used. And it is recommended to avoid areas of scars, bruises, sores, or tattoos. Premedications can be discontinued once the patient has tolerated a full treatment dose or their 76 milligram dose, and also tolerated the previous dose without any cytokine release syndrome. Starting 1 week after the first full dose, patients then receive another full dose of 76 milligrams. Patients then receive the same dose on a weekly basis. At week 24, if patients have achieved and maintained a partial response or better for at least 2 months, patients then can move to bi-weekly dosing, which will still be the 76 milligram dose. At week 49, if patients achieve and maintain at least a partial response for 2+ months, or the same response as previously on bi-weekly dosing, then patients can move to every 4-week dosing at the 76 milligram dose, and then they continue this until progression or unacceptable toxicity. If patients experience delays between doses, please refer to the package insert for specific dosing and step-up information for how to re-step up a patient. It is expected that elranatamab is metabolized into small peptides by catabolic pathways. There are several adverse effects to monitor patients for after their doses, including injection site reactions, myelosuppression, neurotoxicity, cytokine release syndrome, increased liver function tests, fatigue, infections, hypogammaglobulinemia, musculoskeletal pain, headache, nausea, rash in up to a quarter of patients, as well as hypokalemia. Cytokine release syndrome occurred in up to 58% of patients who received elranatamab in clinical trials. A majority of these reactions were grade 1 or 2, with 44% of the reactions being grade 1 cytokine release syndrome and 14% being grade 2 cytokine release syndrome. Grade 3 CRS occurred in just 0.5% of patients, and then CRS did recur up to 13% of the time. The highest percentage of patients did react after dose number 1, so 43% of patients, and then 19% of patients reacted after dose number 2. 7% of patients reacted after their first full treatment dose, and then 1.6% of patients reacted after a subsequent treatment dose, so like week 2 or beyond. Neurologic toxicity such as headache can occur in a fair number of patients, up to 18% of them. ICANS or neurotoxicity with a depressed ICE score occurred in up to 3.3% of patients, but most of these reactions were grade 1 or 2. If patients experience cytokine release syndrome, they may experience a decrease in cytochrome P450 activity. So if a patient is on a sensitive substrate medication, we may need to watch those patients more closely for adverse events. It is recommended to give antiviral and pneumocystis prophylaxis while patients are receiving elranatamab, and it is also recommended to consider monitoring IgG levels to assess for hypogammaglobulinemia. Hypogammaglobulinemia can occur in up to 13% of patients. Prescribers and pharmacies must enroll in a REMS program due to the risk of cytokine release syndrome and ICANS. Patients and caregivers must be counseled on the risk of CRS and ICANS, and patients should be instructed to carry a wallet card stating that they are undergoing treatment with Elrexfio. And it is also recommended that patients do not drive motor vehicles or operate heavy machinery for 48 hours after completing their first 3 doses of elranatamab, or if they are experiencing any change in their cognition. Thank you so much for watching, and if you have any questions for me, I'll do my best to answer them in the comments below. And if you like this video, please subscribe. Thank you.